Right, good afternoon, everybody, and thank you for having me. It's a pleasure to be here. So today I've been asked to talk about cardiovascular disease in women's health, but I purposely added menopause in there because cardiovascular risk in women goes up after menopause. So just to illustrate that to you, this study compares cardiovascular disease incidences in women, pre-menopausal and post-menopausal. And you can see no matter which age group we're looking at, the incidence is much higher in those post-menopausal. So, to talk about cardiovascular disease today with our women, I think it's important to first understand menopause. So menopause is actually a retrospective diagnosis. So what I mean by this is that you can only make the diagnosis once the cycles have completely stopped continuously for 1 year. And this often occurs around the age of 52. And often when you see these women, they will present many menopausal symptoms, and this can very significantly affect various systems of the body. But prior to menopause, they can still develop many symptoms, and this period we call the perimenopause period. So this is the transitional period to menopause. So the symptoms that these patients may present to you with completely vary, from hot flushes to night sweats, mood swings, anxiety, depression, palpitations, recurrent urinary symptoms, brain fog. So you can see these women in your clinic will do a full workup and not get anywhere. And perimenopause and menopause is something to think about. But the other thing that these ladies will not speak to you about is their risk of heart disease and bone health, which is a silent thing that occurs alongside the perimenopause and menopause period. So today I'll be concentrating on the cardiovascular disease side. So generally speaking, this is a global impact. We've had lots of talks over the last 2 days talking about heart disease and how high it is. And specifically looking at women, it's the leading cause of death in our women, contributing about 30% of death in women each year globally. And that was stated by the World Health Organization. There are so many statistics out there, and I didn't want to bombard you all with them, but I specifically picked this one. So when you look at those patients that that died from coronary heart disease, if you look at their history, 64% of those women had no symptoms whatsoever, and 50% of the men had no symptoms. That's quite significant in both genders, but it's much higher in the women. And the incidence of heart disease in our women lags behind men by about 10 years. So when we talk about heart disease, we all know the risk factors. We've been hearing it in our talks, and we deal with it day to day. So high blood pressure, high cholesterol, diabetes, obesity, smoking, drinking alcohol, physical activity being reduced, and stress. So let's talk about how menopause affects these risk factors. So I've highlighted the ones there that are directly impacted by the menopause period and the perimenopause period. So high blood pressure, cholesterol, diabetes, and obesity. So it's important to note that during the perimenopausal period, so before we hit menopause, these women can gain a lot of weight, each year about 1.5 kilos. And so the perimenopause period can last 10 years sometimes. So you can imagine, these women that are struggling to lose weight, and by the end of it, they're quite big, they've got high cardiovascular risk factors. And the reason I say they've got high cardiovascular risk, the weight that they gain tends to be around the abdomen, and we know that weight around the abdomen is associated with high risk of heart disease. So as we go through menopause, the estrogen starts to drop, and estrogen actually plays a very important protective role. So I'm not going to go into the nitty-gritty of it, but I think that's the real thing that I want you all to understand. This is a diagram that just shows the natural progression of atherosclerosis developing in our blood vessels. And as you can see, the age of 45 to 55, that plaque developing, and that's around the period of menopause. So what estrogen does is, when it goes down, we lose the protective effect it has. So what it does is, it avoids normally us getting arterial stiffness. So as we hit menopause, the arterioles become stiff, and this leads to atherosclerosis. The stiffness of these arterioles can also lead to hypertension, but earlier I mentioned to you about the weight gain that we gain around the abdomen, and that we also know is associated with increasing our blood pressure. It's not just estrogen that plays a role in getting cardiovascular risks, but also the increase in FSH, which is also associated with perimenopause and menopause. So it leads to obesity and increased cholesterol level. So how do we manage these women? It's the same as how you manage your general population. So eating healthy, exercising regularly, smoking cessation, alcohol cessation, managing stress, having good quality of sleep. So these are all things that manage our cardiovascular disease. There was an excellent talk yesterday by one of the colleagues saying how even if we know patients have high blood pressure and they are on medication, often, I think it was 30% or more than that he said their blood pressure is still not controlled. Part of the reason is because with high blood pressure, it's silent, so patients don't have symptoms, they don't take it as seriously as we do. But if you tell these women that controlling these lifestyle changes also contributes to controlling the symptoms of menopause, they may listen to you. Regular exercise, eating healthy, having a good night's sleep, these have been shown to reduce the symptoms associated with menopause. And these symptoms can be very detrimental for these women. And often we don't take that into account. So they're more likely to actually listen to you and make those lifestyle changes. On top of that, we know that resistance training, eating healthy, not smoking, these also contribute to good bone health. So by spending that extra time with these women, you're going to be able to manage their cardiovascular risks, their menopause symptoms, and their bone health. So, despite lifestyle changes, some women still actually need HRT to help control those menopausal symptoms. And I purposely wanted to talk about this with all of you. So as a family medicine doctor, I see women all the time with so many symptoms, and they tell me that they've seen medical doctors and they've talked them out of HRT. And this is understandable because back in 2000, there was a big study called the WE study. Does anybody know about this? No? So it was a big study which actually offered a lot of physicians from prescribing HRT because it showed that HRT increased the risk of heart disease and cancer. But that study wasn't a true reflection of the people that we're treating in our clinics. That study, I think about 2/3 of the women actually were about 60 years old. But perimenopause can start from the age of 40 or even before that. And so by dismissing them, we're then not giving them the HRT. So now there's been many studies since then, and that's shown that if you start HRT, it can actually play a part in reducing cardiovascular disease. If you start it over the age of 60 or 10 years after the menopause, then there isn't any protective effect for these women. And also there is a slight risk because they're older. And so if you were to give them HRT, you would think about which form. So they're more likely to be on the transdermal route, which has no cardiovascular impact, and on the lowest dose. We'll go into detail shortly. So earlier I showed you this diagram, just the top row, and it showed the natural progression of the blood vessels as we age. If you introduce HRT early, then you have that woman has not lost that estrogen protection that she had previously. And so the formation of plaques doesn't progress as it naturally would. If you introduce HRT later, as you can see in the last row, after they've developed atherosclerosis, you can see there is no reversibility of that blood vessel that's been damaged. So I guess then the question is, why is HRT not licensed for cardiovascular disease? So HRT is only licensed for the symptoms of menopause. Well, when you look at 30 randomized controlled trials, it showed that there was a significant reduction in the mortality by about 39%. But that confidence interval is quite wide. So it's from 5% to 61%. And so we can't fully say, look, this is going to change your risk of a heart disease. And hence why I think this is why it is not licensed. When initiated in women over the age of 60 or after 10 years of postmenopause, it's been shown to have no impact with regards to their cardiovascular disease risk. It is important to note that HRT in patients who have already had a heart attack or some sort of a stroke, we wouldn't initiate HRT in them, or if they have uncontrolled cardio risks. The form of estrogen is also important. So there are different types of estrogen. You can take in the oral form or through the skin. And the skin, the one that goes through the skin, whether it be patches or gel, has been shown to have no impact in increasing your risk of heart disease because it does not get bypassed through the liver, and so it does not play a part in increasing your risk of developing any clots. So HRT, not licensed for menopausal symptoms, is licensed to menopausal symptoms, but not for cardiovascular disease, and should not be pushed to the side. It should be explained to the lady. So I mentioned that a lot of physicians are worried to give our patients HRT because of risks of heart disease. So I've gone through that now. But the other worry that clinicians have is cancer. So estrogen, when you get estrogen, it increases the risk of endometrial cancer, so cancer of the womb. So to eliminate this risk, we also give progesterone. But when you give a combination of estrogen and progesterone, this increases the risk of breast cancer. And this is what scared doctors and patients. But you have to remember, it's all about relativity. So this is a study from the UK. The top line shows you, so if they took 1,000 women and they looked at the risk of breast cancer. So in the UK, in the general 1,000 women that we have, 23 of them will develop breast cancer. Now, if we get HRT, it shows that the number of cases goes up by just 4 women. But that's the same as giving the combined pill. But if you look at those that are overweight or obese, that's the second row from the bottom, it's much higher, the risk. So it's all about relativity. Yes, it does increase your risk, but very minimal, and you would monitor that. So to conclude with, menopause increases your risk of cardiovascular disease. Women that are higher risk are those that go through menopause much earlier. So if they go through it before the age of 40, so primary ovarian insufficiency, these are high candidates that should be actually put on HRT to replace the estrogen that they should have had. So if you see these women, just think how high risk they are, do the regular screening and make sure they're on HRT, or refer them to a colleague to initiate HRT. For women that you see that are in their perimenopausal period or in their menopausal period, it's an opportunity for you to review their cardiovascular disease and talk to them about lifestyle changes to help them in the future and in the long run. So each woman should have a careful risk-benefit analysis done for HRT if they're suffering from symptoms. And when you give them HRT, you will help them with relief of symptoms, protection from osteoporosis, and cardiovascular disease. The reason I mentioned osteoporosis is we all know that our bone builds and breaks down and then rebuilds. And estrogen plays a major part in the rebuild of our bone. So as women start to go through the perimenopause period and the menopausal period, the bone slowly breaks down, and we need to encourage that to be rebuilt. And so that's a lot of resistance training, not smoking. But if they go down the HRT route for the menopausal period, menopause symptoms, it also helps with maintaining their bone health. Thank you.